Okay, good morning for those who are in the US, and good afternoon for those of you guys in Ethiopia, and thank you for joining us. My name is Gurma Tafara. I'm a vascular surgeon here in the United States, of course, originally from Ethiopia. I am the organizer for this webinar, which we are going to do for the next 10 days or so. It is absolutely a pleasure for me to bring some expertise to discuss with you, and the discussion is going to be both ways on this new disease that is really killing and causing a lot of destruction from both human lives as well as economies across the globe. So this is a time when I think it's good to see all of us coming together and maybe sharing some ideas as well as strategize together, hopefully to fight this invisible enemy in an organized manner. The reason we are going to do this webinars is really to also create the connectivity between those of us who are across the Atlantic and with those of you back home, create a system where we can have easy way to communicate experiences. And we need to actually do this also outside a formal webinar like this. So we are hopeful that some of our Ethio-American Doctor Group physicians who are specialists in intensive care and infectious diseases would partner with your individual institutions and be available to support with some ideas and thoughts. I just want to say thank you to those who are going to be presenting over the next few days. And if you look at your emails, there is a detailed description of all the presenters and the presentations, the topics, at what time. And so to make it easy, we have decided to do the presentation every day during weekdays at 3 p.m. And also we decided to make it one Zoom address. So basically the same Zoom invitation you got will work every day at 3 p.m. If you want to join us. I don't want to go over the content of the next webinars because it's going to take so much time, and you have the copy so you can read. You can also read about our presenters. So I would encourage everybody to turn off their videos except for the presenters, and also mute your phones because we hear a lot of background noise otherwise, and that will be very difficult then to listen to each other. The second piece I really want you guys to do is I have sent a couple of text messages in the chat function. So you can respond on that text message if you have any questions that you want me to ask the presenters. You can imagine with so many of you online, we cannot really have people talking from the other side. So please text me in the chat section if you have any questions about this. And that I'll keep sending a little bit of a reminder so that you can see where I am at. And my name here is on top. It says Operation Giving Back, and that's me. Otherwise, for today, we have two presenters, one from Ethiopia, from Addis, and one from the US. The first presenter is Dr. Theodros Haile, who is, as you all know, a dedicated clinician and academician at the College of Health Sciences at Addis Ababa University. He's an assistant professor, consultant internist, pulmonary and critical care physician. He is also currently the head of the Division of Pulmonary and Critical Care, and as well as the Department of Internal Medicine at the College of Health Sciences at Addis Ababa University. He is actually one of the individuals who has been tasked to carry on the organizational structure from COVID-19 perspective in Addis, at least at AAU. And following him, we'll have Dr. Elias Ashame, who is a graduate of Gondar University many years ago. He's currently practicing here in the US. He is an infectious disease specialist as well as boarded in critical care. He is primarily working, I think, now as a critical care physician in one of the community hospitals. He's actually involved in global health activities in Ethiopia, where he comes for starting educational program on respiratory therapy. So without any further delay, I would like to start with Dr. Theodros to go first and share probably his thoughts, and he has some slides, probably over 20 minutes, and then subsequently Dr. Elias will have about 20 more minutes to add some of his introductory remarks, and then we will open for some questions. So Dr. Theodros, the floor is yours, and please go ahead and share your screen so that we can all take a look at. And Malaku, please mute everybody. Thank you.
Okay, thank you, Dr. Girma, for the opportunity. And my talk, as the topic you gave me was on the burden of COVID-19 in Ethiopia, but I have somehow modified the topic. I added also the response that we are doing, what we are doing. I think that because that also affects the burden. So the outline of my talk is just I'll speak more on the global burden, African and Ethiopian burden of the disease, and then I'll talk on what the public is doing and the level of awareness and what public health measures has been taken in Ethiopia. So as of today, the number of people globally affected by coronavirus has exceeded 1 million and more than 53,000 deaths. And the good news is that there are more than 230,000 patients has recovered. So this is the map of COVID as of yesterday. And as you can see, the epicenter is now US, but also part of Europe, particularly the Southern Europe, is affected much. And Ethiopia, the rate is like, below 49 people affected per million. So it's still a small number, but still there are problems. And if you see the cases per million, it's in Ethiopia it's 1.28. Actually, it's a little bit changed as of this morning. There are 6 additional cases, so it's the fraction maybe a little bit affected. This is global cases and deaths, and if you see here from the right one, the blue one, if you see, it takes around 6 to 7 weeks to reach to the peak, and worldwide it started in January 22, and then now in March 14 it spiked, and also the deaths also has similar pattern. And when you bring this one, this is the daily cases, global daily cases. It's still on a rise. This is as of March 31. And this is the case in Africa. And the first case in Africa was reported in Egypt. It's on 14th of February. And now, as of March 22, just it has started to peak. And now we have in Africa more than 6,500 cases. When it comes to Ethiopia, the first case was reported on the 30th of March, And now we are having 35 cases. The six of the, just it was 29 up to the day before, and 6 were added this morning. So the total is 35. And 3 regions, Amhara, Oromia, Addis Ababa, and Diaspora are affected just by this disease. And when you see the transmission scenario in Ethiopia, it's so far it is a cluster type of transmission, not yet a fully community transmission, and mostly they are imported cases or travelers who came from places where this COVID infection is high, where COVID transmission is high. And so far, no report of COVID among health professionals. And this is, it's a report of the 29 cases that were reported up to the day before. This, you can see the pattern that the pattern of increment per day is like from the first day. If you see on the 3rd day, that's on 15th of March, it increased by 300%. So any figure of increment more than 1%, it shows that the disease is increasing. All along, if you see like 25, 20, 50% increment per day. And when you come to the demography of affected people, so far it was, the test was done. We are doing here PCR test, and it's more than 1,000, it was done in more than 1,100 people. And so far we have 35 confirmed cases, and the average age from what I have got, you know, I was able to trace only 20 patients, and the average age among these 20 patients was 42, but it ranges from 14 to 85. And this is probably, this is also the sex distribution is from what I found from the 20 patients. Maybe a misleading one because I couldn't able to access all the data. So probably it can be equal proportion, or the females may be higher. Just don't take it. This is only a part taken from the part of the data. And this is the graph of the total cases. This is up to the April 1st, but as of today, that's April 3rd, it has become 35. And if you see the pattern, it's on increment. It's even in the last few days, it has doubled. In less than 4 or 5 days, it has doubled. And even though there were interventions taken, like for example, as I said, the first case was reported on the 13th of March, and the first action was taken was closure of schools and public mass gathering and the like, and that was on the 16th of March. And later on, several consecutive actions on the 20th of March, 25th, 26th, and 27th of March. Several public health measures has been taken, but despite that, the disease is on a rise. And this is distribution by region. It's mainly, most of the cases are located in Addis, but also reports from Oromia, Diaspora, and Amhara region are there, a few cases. And with regard to the public awareness, education has been given on the ways of transmission and on the preventive methods through mass medias. Even some politicians has been teaching the people in the streets. But despite that, so the people are not, you know, just adequately adhering to the, particularly the distancing. So even though government offices are closed, people are not staying at their home. So just people are not just really understanding the seriousness of the problem, despite the government's action. And these are some of the public health measures that WHO advises to be taken to control the disease, like on individual level, this you can advise hand hygiene, respiratory etiquette, and masks for symptomatic individuals, isolation and treatment of ill individuals. Most of these are being done actually, and monitoring symptoms of healthy contacts by quarantining them, travel health advice, and environmental cleaning. And also we are doing like, people are being advised to avoid crowding or mass gatherings. School closure, it has been done, it's actually one of the first actions that was taken. Public transportation is not yet closed, but they are told to use only 50% of their capacity. Workplace closure, it's only the governmental offices that has been closed, and public health quarantine, it's particularly as of March 27, every person arriving to Ethiopia is quarantined for 14 days. So these are the measures that, public health measures that the government has taken on 16th of March. That is the first action, 3 days after the first case. School and sporting events and public gatherings were suspended for 2 weeks, but now it hasn't, now we are on the third week. On 20th March, Ethiopian Airlines suspended flights to certain countries which are highly affected by coronavirus. Anyone entering the country should undergo a mandatory self-quarantine for 14 days. On the same day, it was told, and nightclubs were closed, but I'm not sure whether it's implemented. And on 23rd of March, Ethiopia closed all land borders and has employed its military to control that. On 25th of March, 1,000 prisoners who had, who didn't commit a major crime were granted pardon to avoid the damage that can occur if the disease get access to the prisons. On 26 March, Tigray region declared 2 weeks region-wide state of emergency, and they have restricted people to stay at home. And actually, subsequently, the other regions, Amhara, Oromia, also did similar things, but they didn't openly declare state of emergency, but did similar actions. Also, southern regions also joined subsequently. And on 29th of March, airlines suspended further flights to 80 countries. And with regard to case management and health services, we are setting up surge triage, screening areas, treatment and critical care units. We are trying to deploy health professionals, and we are trying to get supplies and spaces. But there are critical shortages and personal protective equipment. And we have requested the hospital and the Ministry of Health to look for oxygen supply also. With regard to the laboratory systems, until recently we had only one testing center, that is the national center, the National Laboratory Center, that's the EPHI, but now I think it's 3 or 4, including one regional in Mekelle, but the other 2 or 3 in Addis. And there is a plan to open more sites in Addis, including Black Line and other regional cities. With regard to resource mobilization, the government has is now mobilizing resources, and people are donating money, and there are also some rich people are dedicating their buildings for quarantine purposes. And we are involved on the training of health professionals. The Ministry of Health has recruited new health professionals, medical doctors, nurses, health officers, and environmental sanitation workers, the like, and particularly the professional societies who are getting involved in training this one. And we are continuing also, we are going to continue with refreshing health professionals who are already employed in hospitals as of next week. In summary, we are in the 3rd week of the epidemic. We are only starting up, and probably we may have the surge after 3 weeks, like at the end of April or the 1st week of May. And so far we have only some cases. However, number of the cases has doubled in the last 4 or 5 days, more than double actually this time. and transmission is still in cluster level, and public health measures are being taken, but the compliance is not great or enough. And I think this calls for a further stringent actions has to be taken to contain this disease. Otherwise, the outcome will be bad. Thank you. I have finished my presentation.
Thank you, Dr. Theodros. You know, a great presentation. Thank you so much. And you know, there are a lot of questions that have been sent to us, which we will revisit at the end of the presentation by Dr. Elias. So, Dr. Elias, could you please share your screen?
Okay.
And so a lot of questions, of course, where we probably may not have enough answers, but clearly the issue of this pandemic is going to hit hard everyone and everybody. You know, as Dr. Theodros mentioned, the first case was identified March 13. You know, what we have seen here is that actually every 3 days, the number of cases doubles. That's how the epidemiology is showing us. And I think it is a little bit later, but it's going to come, and clearly having these discussions is important so that we can all prepare not only with the personal protection devices, but also with knowledge. So let me give the opportunity for Dr. Elias to also summarize and talk to us about his perspective, because he is one of those who are in the front lines, because he is an intensivist, and so they see already in the Washington, D.C. area COVID positive patients, and he has been actually treating them in the ICUs and admitting and intubating for airway purposes. So Elias, the floor is yours, please. And you have about 15 minutes plus minus 5. Thank you.
Thank you, Kerma. And thank you everyone for, this is a great opportunity actually. And can you guys hear me well?
Yes.
Okay, thanks. So Dr. Theodros did a beautiful presentation about the current status of this disease. I think my plan today is actually just, it's as the title indicates, it's an introduction, so we have no intention to go in detail about the management. I'll try to move on directly about talking briefly about what coronavirus is, and especially about COVID-19, since Dr. Theodros covered this is, as you can see, I mean, this slide tells it all, I think. This was about 9 days ago, as you just, so the latest figures, it's more than doubled. So this is when I prepared it. So what is it? So we do know about coronaviruses. Our first epidemic was from 2003, which was a SARS-CoV-1. And the other one was a major one, was 2012, the Middle Eastern Respiratory Syndrome. So as you can see on this slide, this one looks like very more related to the first one, at least RNA sequencing so far. But both of them had a significant impact on people's life as well as economic damage, but not even close to this one. And they seem to have similar binding domain structures and can bind to angiotensin receptors. But yeah, you probably heard about the conflicting information whether we should use this medications for hypertension and cardiac patients or not. I know WHO came out with a recommendation. It's okay to use, but that's exactly why. And it so far we think it's a bad origin, as most coronaviruses are. seems to have bats as reservoir, usually original hosts, but they easily switch hosts, and they do have intermediate hosts as mammals as well. And this seems to be what they call it prone. High risk of mutations. This is what's called error prone genetically. So you can switch any time. And I know one of our colleagues will go in detail about this. And we all know that this started in the live market in Wuhan region somewhere in November, which we have experience with avian flu as well, which started episodic origin, and it started widely spreading, obviously, and now we do have more cases outside of China than China. So the purpose of this topic is to talk about what is presentation in critical ill patients. So far, again, there is a lot of knowledge gap, and some of us a couple weeks of experience, and some have none, and some have probably 2-3 months of experience. But so far, the data which came out of China as well as here in US, and majority of them present with respiratory failure, with acute respiratory syndrome or ARDS. And we do know that now person-to-person transmission has been widely documented. So this slide speaks about what are the most common features. This is based on the out of one of 55,000 lab confirmed patients. So as you can see in this slide, fevers tend to be the major one. But again, more data is coming out of here that fever, they don't necessarily have to have fever. Although fever is the most common features, anywhere range from 50% to 87% on this particular data. And the next common feature seems to be dry cough. The rest of them are very specific, but I want you to pay attention, because if you see at the bottom, some of the presentations are non-specific, like diarrhea. So just from personal experience, one of the first few patients we've seen actually presented with diarrhea. So the story goes, she presented with diarrhea, seen an ED, sent home, and came back in 2 days, again with severe diarrhea, abdominal pain, and then revealed contact to COVID-19 positive patient. That's when the physician decided to test her. She ended up being COVID patient. Now, she went on to develop respiratory symptoms after coming to ICU. So her initial presentation was diarrhea, but then she started having fever, respiratory failure, but she's one of the favorable outcome, which she's home right. So what I'm saying is, like I said, this knowledge gap, I like to emphasize that, because they could present in a lot of ways. They don't necessarily have to have fever or respiratory symptoms. And specifically speaking about ICU, so I think this is where the challenge will be, because majority of the patient will do fine. We do know that from experience thus far. But about, at least based on this particular case series, about 5% of them will end up in ICU. So it depends. So that 5% could be significant, and the health system can be challenged to provide care. And we've seen it in Italy. We have seen it even in China. The case fatality rate varies from region to region, depending on their capability of the health system. So I think this is very relevant to Ethiopia, obviously. And I think the information coming out of Ethiopia, you guys have more information than I do. Right now, I think the available ICU beds are probably not more than 400 in the whole country. And taking this 5% with the current projection, which is coming out of Ethiopia, you probably need thousands of ICU beds. So that, I think that's going to be the major problem, and the main purpose of this is to help with taking care of this critically ill patient. And the case fatality not only depends on the severity of the disease, whether the availability of delivering care when they are sick, like respiratory care, hemodynamic support, and on and on. So this emphasized the importance of health system capacity, which is very relevant to Ethiopia. And we're seeing it here, even here in, as you probably hear it daily, New York City is being one of the most challenged in that aspect. And it's a rapidly moving storm. Just from personal experience, a couple of weeks ago, we didn't have a single COVID patient. Right now, we have filled 2 COVID units, 24 beds, and we just opened the 3rd unit. So this is how fast it can move. And I think Ethiopian experience is also showing that, because in the last week or so, you guys are already at 36 cases. This is where we were, as Dr. Girma was pointing out a couple months ago. The first case in US wasn't found till January 21st. That was in Washington State. And right now, we are almost 250,000 cases, confirmed cases, and with thousands of deaths. I think the last figure is about 5,000 deaths. Unfortunately, people who tend to do not good are people with underlying illnesses. This is consistent even here. The data with underlying cardiovascular disease and COPD and diabetes and any kind of immunosuppressions. This is just a graph that shows how fast it's moving in different parts of the world. And so age tend to be one of the most important factors in requiring ICU admissions. But so right now, though, our experience is a little different than coming out of China and even Italy, is because even in New York City, almost half of ICU admissions are under 55. So I know one of the advantage we have in Ethiopia is majority of them are young. And we hope that that works for our advantage. But even young people can actually get sick and die of this disease, especially with underlying comorbid conditions. And one of the features of this disease, I think, when we talk about the clinical features on the next few presentations, is it is very gradual deterioration. So I think they coined a new term actually they call it silent hypoxic respiratory failure. It actually, they don't just require intubation in a couple of days. They usually just smolder. They're requiring 2, 3, 4, 5 liters of oxygen. And by 9-10 days, they usually end up in intubation. And even after intubated, unfortunately, which this will affect your resources, because they tend to require mechanical ventilation for prolonged period of time. The data came out of Washington State yesterday, showed their average intubation is about 25 days. So, your ventilators will be tied up essentially. And this is just confirm most of the people who end up dying are elderly. If you are over 75 and end up in ICU, your chance of coming out of ICU is very, very low. So it's going to affect our elderly. So I think that's the focus should be. And but you can see that you can even affect, like if you see 50, 59, 40 to 49, still there is a significant amount of fatality rate, which is higher than flu on this one. So for us, we are coming out of the flu season, so this no more going to be the case, but I don't know when is the flu season in Ethiopia. So, but if it can overlap symptom-wise, so differentiating this disease from other pathogens, especially influenza, is very important. And where you get your specimen is going to affect your negative predictive value as well as your specificity. Lower respiratory samples tend to have a high yield. We know that, which is different from influenza. Influenza nasopharyngeal is as good as bronchial alveolar lavage or endotracheal aspiration. But this one, the lower tract samples have a positive more, because we do know that there are false negatives anywhere as low as 70%. So that sometimes if your clinical suspicion is high enough, you might have to consider repeating it, but then we're talking about a limited resource here. So that's why it's very important to have rapid access to diagnosis. And I'm surprised and pleasantly surprised actually to see that you guys are able to test more than 1,000 patients, which I guess you have the access to the testing, which is good, because that has been a problem here. And I don't know, you didn't describe what kind of testing you guys have. What's the turnaround? And if you touch upon that, that would be wonderful. And so the most important is patient triage and infection control. That's very important, not only to tackle this transmission among the community, it's also to protect the healthcare. So this just show you what's the clinical course. This is based on Wuhan data, but this is consistent even here. What are the most common complications? Shock, surprisingly, doesn't seem to be common feature of this disease, but significant number of them will go on to develop hemodynamic shock, and including acute kidney injuries. And we are also seeing cardiac injuries, including myopericarditis. One of our patients right now in the unit actually presented with significant EKG change with left bundle branch block, which is a young gentleman, 35-year-old, and with troponin leak, and it was turned out to be COVID positive. So the only way we tested him was because he has positive contact. So it's just this can manifest as but it's not as surprising because coronaviruses tend to affect the heart muscles and cause myocarditis, including myopericarditis. So, and this is just a graph representation of that. And from this slide, as you can see, steroids on this particular data tend to decrease risk of death, but most of you probably aware that most of the society's recommendation about using steroid is non-committal, I would say, because number one, the data is not there. Number two, based on our experience from prior coronavirus epidemics, especially in the first one, SARS-CoV-1, it tend to increase mortality. And the other fear is it increases RNA replication. So that will have an impact in transmission. But So our society, for example, do not recommend using of Solimedrol or any kind of steroids. But if you have a reason to use it for asthma or other, yeah, but you can continue to use that. So another thing is what we call risk stratification to essentially prognosticate and see which patients will do good or will end up with complications. There are a lot of inflammatory markers we use from admission on and during their ICU admissions. And this is based on a few data that some of them include LDH, D-dimer, CRP, and ferritin. And again, all of this is anecdotal because this is, as the name indicates, it's a novel virus. So we're just learning as we go. This is a simple few data from Washington State. This is one of the states we start seeing patients early on, and the males tend to do poorly, which it looks like Ethiopian data is going to be consistent with that. And comorbidities, including CKD and CHF, don't tend to do well. And if you end up in mechanical ventilation, fortunately with age and comorbidity, your chance of recovery is minimal. So the mortality rate in ICU is unfortunately extremely high. This slide shows how infectious this disease can be, but I will not spend a lot of time on this. I know Dr. Dawood will touch upon this one. And so this is a famous flattening the curve. So this is all the social distancing would be important is to not, so that the healthcare system can have time to take care of patients to avoid this mountain peak. There are a lot of modeling systems right now. The Murray modeling seems to be the most famous one. And I know my information is Minister of Health is planning to use that. And some of the modeling, even in Ethiopian, it's early on because there's lack of data. You only guys have 36 patients right now, but based on that and other people's experience, it's very scary. And so this could last for months. And I don't know what, especially with the healthcare system like Ethiopia, whether it can handle this epidemic or not. That's questionable. And so that's why it's very important to have a plan, surge preparation, as every facility does. And you need to know how many ventilators you have, where you're going to put the patients, plan A, B, C, D. And that will actually, that's one of the most, I think, important factor in determining people's outcome, whether they're going to live or die. So that's more of a political and resource decision than healthcare. I think that would be my slide. Thank you.
Well, thank you, Dr. Elias. It was an outstanding presentation by both of you. There are a lot of questions, which I'm going to actually read from the chat section. And please, everybody, keep your phones and computers muted. And if you have questions, send it through the chat function, and I'll be happy to read it out. So I thought I needed to first plug in a couple of things. Number one is that we have next week, Monday, a presentation by one of our members. She is anesthesiologist at Baylor College of Medicine in Houston, and she is going to talk to us about infection control and airway management. And you can see how this ties into the whole discussion about COVID, both from the airway management, particularly in these patients. It's very critical that some guidelines be, taught and discussed. and also infection control, because it's really very pertinent. So I invite everybody to join us on Monday at 3 p.m. to hear her talk and take some of your questions. So let me just go over the list of questions that came through, and I'll just start with some priorities. I think the first one was from David, and the question was around how do you plan and how do you protect healthcare professionals? And it goes both for Dr. Tedros and Dr. Elias. If you guys can tell us about the PPEs that you have, and how protective is it, and how rationed is it? And I will maybe start with Elias and then go to Dr. Tedros. Elias, did you hear my question? Maybe you're muted. If not, Tedros, you want to take the question from your side?
Okay. With regard to how we plan to protect the healthcare workers, we have prepared a plan. This is a hospital plan, and there are also areas that we give priority for now. Because we have only limited face masks, for example, we have to prioritize. So we gave to the guards, to the emergency people, to the triage, to the critical care, and pulmonary side, and ID, infectious disease clinic. So we are prioritizing that way. But now with the recommendations that are coming to provide face masks, at least the medical or surgical face masks, to all health professionals in hospital. We are discussing with hospital management to provide to all health professionals working there. But for those procedures which requires airborne protection, we are recommending N95, but we have very limited N95 in the hospital. So we dedicated the small amount we have currently for the isolation, for professionals who are working in the isolation room. And also they are advised with all protective equipments like gown, goggle, cap, and other necessary protective equipment. But we have really a shortage of all this, and we have requested, we have prepared a list that we need, and we have requested the Federal Ministry of Health to provide us, and also the university management to purchase for us. So we are doing this way. We have classified based on the need.
Dr. Girma, can I jump in to answer a few of those questions, if you don't mind? Hello?
Daud,
Daud, go ahead. Daud, go ahead.
Yeah,
we just have we just have a few minutes, so just be brief. Yes, okay.
Yeah, this is a very important question. As you know, many Italians have, physicians have died from this one. So we are going to come out with recommendations together with EMA, Ethiopian Medical Association, about recommendations. But a couple of things hospitals can do is triage patients who are suspected of COVID. One of your wings should be the first emergency side. Have a specific phone number in the emergency room where patients can call if they have respiratory diseases. Try to create a rotation base of physicians and medical professionals like nurses, so that in case you can work 2 weeks and 2 weeks rather than 1 day and 1 day. So that will give you some time. The other thing is we're looking very closely about chloroquine prophylaxis for those who are exposed, not yet approved, finalized, but we will look at it. And if it is really effective, we would recommend that for physicians. The good thing is our peak is going to be late May or June. By that time, a lot of people will help us in terms of protective equipment. Thank you.
No, thank you. Elias, is there anything you want to add?
No, Dr. Dowd, I think I answered it very well. But yeah. Can you hear me?
Yes, we can. Yeah, I can. So,
Okay.
so if you don't have much to add, I think, the mask question, the next question about mask and protective devices, what the common theme is, what do you think about masks? Should everybody wear masks? Is it something important? Data is all over the place. And so there is a question from a few people asking about use of mask in general. What do you think? Is this airborne, aerosolized? What is the consensus at this point? And you can give maybe the scarcity situation where if there is no mask, what to do? And if everybody can get a mask, is it okay to wear a mask? So that was another question. Maybe Dawood might be the good infections doctor that can answer this question as well.
So I will make it very simple. The science will come later. I actually tweeted yesterday saying that we don't need a randomized controlled trial for a parachute if it is working or not. Okay, you don't jump from an airplane. If it was not for scarcity, this would have been an issue. Whether it is droplet or aerosolized, somebody having a mask to protect the sneeze and the cough and the aerosol or droplet to come out would not hurt. So our dream is for every Ethiopian to have some kind of mask. But of course, masks are scarcity right now. So what I recommend is every professionally produced, standard, tested mask should be only for medical professionals, period. Should not be sold in a shop. Hospitals and universities and Federal Ministry of Health should not give it to anybody else. But any locally made mask, whether it is a garment factory, let it be Gabi, let it be Fota, whatever it is, to cover your mask when you cough should be the goal, and it is very achievable and very, very important. Hong Kong, Singapore, Czechoslovakia, who have very low rates, have a very high use of masks. If you have Twitters, go to my Twitter and look at what I am tweeting about masks. Thank you.
So great. So this next question goes both to Dr. Elias and also Dr. Theodros. And I understand, Dr. Theodros, you don't have yet a patient, so it might be a little bit too much to ask this question. However, a resource utilization question comes up about how do we use, in the scarce situation that we are in, how do we use our ICU resources? Who do we admit? How do we define? Do we have a some kind of a guideline and to select, who is really the person we should take to the OR or not? So, any thoughts about how to prioritize, basically? If you have any plans or if this is something work in progress, that's fine too. Dr. Theodros.
As you said, because we didn't have patients, we didn't come up with this to answer this question, but we have, there is a team that's led by the college, and they have asked us to prepare a guideline, to give priority. And probably one of the factors that we may consider is age and comorbidities, like what they did in Italy. And its guideline is being prepared by the Federal Ministry of Health, but it has raised some ethical issues, and we are waiting for that general guideline from the Federal Ministry of Health. I just have to leave you because I have a second video call. So sorry, just I have to leave.
I really appreciate you coming on the call, and we are going to keep Dr. Elias and Dr. Dowd for a few more minutes to answer some additional questions that are in, and I'm looking forward to seeing you on Monday.
Okay, thanks. Okay.
Thank you. So Dr. Elias and Dr. Dowd.
Can I say a couple of things?
Yes, please go ahead.
Can I say a couple of things?
Yeah.
No, I just want to.
Go ahead.
Can you hear me?
Yeah, we can hear you. Please go ahead. Elias, we can hear you.
I'm sorry. I want to answer the last question briefly.
Okay.
Who do you admit
to ICU or not?
Yes.
So that's going to be crucial, because especially with the resource limited country like Ethiopia, especially ICU wise, so your criteria has to be very stringent. So because remember, most of these patients can actually go home with appropriate instructions with infection control. The very few of them should come to ICU, especially ICU beds. It's very limited resource, so you have to have strict criteria which patient needs to come. It's usually the same as any ICU admissions, with hemodynamic instability and significant requirement of oxygen with respiratory failure and multi-organ failure, right? So nothing special, but just you have to have criteria for ICU admissions, and it has to be strict and enforced.
So I think the answer to this is, of course, depends on your resources, and this can be challenging and press against all the ethical boundaries. However, those difficult decisions have to be made, and those decisions, I think, are made locally, and clearly having guidelines from the Ministry of Health around this issue is going to be very critical. So I have another quick question that came, particularly when you talk about age. Yes, one of the attendees actually had a very smart question, whereby he says, well, we have young people, but a lot of our young people have also rheumatic heart disease and valvular disease, and what do you think about that? So what are your thoughts about mortality and morbidity for that kind of a group of population?
So the short answer is evidence data driven or not. So I think some of them the answer is easy, because based on the data so far, the older with chronic medical condition tend to do poorly. So we're talking about critically ill people here. Infection wise, everybody can get infected, but based on data so far, which came out of Wuhan as well as here in US, and including Italy, a majority of them are elderly, above 65. Majority of them are with chronic medical conditions. Now, younger, who's a significant amount of smoking history, and that's a different story. But I think rheumatic diseases is a little funny, actually. Dr. Dowd just mentioned one of the medications we're using and we're planning to use. Most of our rheumatic patients tend to use them, like Plaquenil, which is hydroxychloroquine. Whether it has a protective effect or not, of course, there are a lot of clinical trials going on right now as we speak. And Dr. Dowd just mentioned that there seems to be some plan to run prophylaxis as taking chloroquine. So I don't know of any data on rheumatic patients and COVID, but it might actually have a protective effect though, using the medication, not the disease.
Okay, thank you. And so one question that is for Dowd is, Dowd, are you still on?
Yes.
Yeah, so risk of reinfection. So one of the attendees asked, is there a risk of being reinfected once you have gone through the infection?
So this is an interesting question and an evolving science, obviously, but it is being looked at very closely. It seems that it is not very common, but there are reports that could look like a reinfection. But by and large, when we have a peak of an epidemic, this is not going to be the big issue. In fact, by that time, probably plasma might have been a treatment, which means that they have a protective antibody. They're willing to share it to someone else. So I would not worry a lot about this issue, but this is something that is evolving.
So one other question from Yudnakacho is there racial disparity, or in terms of severity, is there any data about racial disparity and severity of disease?
Not seen up to this time. The other factors are much more importantly, clearly being seen. The factors of comorbidity, hypertension, diabetes, even obesity. If there is any racial segment who have more of those diseases, then it would look like, and that is why it needs a much more extensive study to see if it is a co-founder or really a true risk factor.
So this goes to both of you, anyone who can speak about herd immunity. Amir Mohammed asks, is there anything like herd immunity from this disease?
So herd immunity, basically, to just make everybody on the same page, is basically enough people have to be infected to have, or vaccinated to have antibody, which is protective, so that the disease will not get enough susceptible host, so it will die in its own. So that means in a city, for example, if 80% of the population is either vaccinated or prior infected and they have antibody, the disease jumps to so many people but cannot infect them. So eventually it ran out of a susceptible host. So that's what herd immunity means. For this disease, for a herd immunity to develop, a minimum of 70% have to have antibody. This is a very tall order. If we are banking our prevention on a herd immunity, we're going to have a big tough time. It's not going to be easy. A lot of people are going to die and a lot of people are going to be sick unless we get a vaccine to create that herd immunity.
Dr. Elias, a question for you. CT scan as a diagnostic modality, particularly in places where there is no testing. Do you think it's a reliable thing to do?
So that's a great question. So CT scans as a diagnostic came out of mostly Wuhan region, but as using it as a diagnosis, the specificity, and its sensitivity is very questionable. So we don't use it, but it does tend to have a diffuse ground glass opacity, especially on the basis. So if you happen to see that with positive contact, you can use it as an additional clinical feature, but you can't use CT scan as just a sole diagnostic method. We don't use it, and it's not suggested to you.
Thank you. And there is a message. This probably is a good message for Dawood to take as as part of the task force from the diaspora, sitting in those meetings. There is one of our audience members here says there is a lot of Ethiopians right now going around with medical masks, and even in some cases with N95 masks on the road, and probably the policymakers may have to weigh on that somehow to make sure to discourage that, or be a little bit more forceful about it. So just take that message back to them, and Dr. Theodros is not there, but someone was asking about the sensitivity of the tests that are available these days in Ethiopia and around the world. I don't know if you guys can answer that question. The sensitivity in terms of diagnostic ability of the COVID tests that are out there now.
Well, the sensitivity of the test is very good. Actually, we are lucky that we are in the developed country category in terms of testing of this, because this is the same RT-PCR molecular diagnostic technologies that we're using here in US, in China, in Europe, as well as in us. So the sensitivity is upward of 90s, of course, 90%. Of course, this depends on how you collect. So one thing that I would recommend the laboratories will know it is train the people who are going to collect the nasopharyngeal swab, and don't make it that everybody collects it, because the biggest factor in sensitivity of this test is how you collect the specimen more than anything else. In terms of specificity, well, that is a challenge, because all PCR tests are very, very sensitive. So they will give you a lot of false positive results. But I think this is not going to be a big of a challenge. Our laboratories are well equipped. We're not having commercial laboratories running around doing these tests. These are being done in very few places. So I don't think that will be a problem.
Malaku, can you share? Malaku, can you share your desktop so that people can see next week's program? And who was asking me to?
I'm sorry. This is Elias. I just want to say a couple of things on Daud. Number one, I think Daud is going to touch upon it on collecting specimens. So you got to be careful. Of course, he's talking about infection risk, because some of the procedures could be aerosolizing, and I know he's going to touch upon that. And because one of the experiences, especially from Washington State, is the first few cases they've been doing bronchoscopy unknowingly and have exposed the healthcare workers. So I think we're learning, and so some of the procedures need to be properly protected. And the other thing is, somebody asked about the PPE. So yeah, you guys have to, evidence-based as well as fear-based use of PPEs. You can't just walk around with a face shield, especially in a hospital without any risk. So I think that whatever we do has to be evidence-based, not fear-based. I know there is a lot of people paralyzed by fear, and especially healthcare providers. So I just want to emphasize on that. We tend to see it here as well. So.
Great. So I think, to be sensitive about everybody's time, we just want to end at this point by saying, hey, join us again on Monday, same time. We have an outstanding speaker. We'll probably be joined also by our ambassador, Ethiopian ambassador to the US, who is actually putting a lot of word out to get some needed help back home. And so if we have an opportunity to engage him, that will be great. So there was close to 100 people at least on this call today. And this call today, or this presentation today, was really more of an introductory to the whole thing that's going to happen in terms of additional thoughts and education around things to do. So we will definitely ratchet this up a little bit more and get into more detail. And you can see towards the end of the week, we're going to talk about mechanical ventilations as well, because these are things that most of you may need to know. Who knows if your major ICU physicians get sick, you may have to jump in and do some work in the critical care. And so there is a lot of discussion that we need to have with regards to preparation. But I think having this knowledge sharing and preparing yourself to with ideas and thoughts as to how to handle this kind of patients in the critical care space, in the operating room, in the emergency department is really, really important. So we are excited to share this with you and actually interact with you. At the same time, we also are very aware of your concerns. We are very aware of the acute shortage of materials, and believe me, there is a lot of individuals here in the diaspora who are trying to put together groups to help with supplies, particularly supplies in the area to protect the healthcare professionals, because you are basically the individuals and the people in the front line. So thank you for joining us today, and we are looking forward to seeing you on Monday. And if you have any specific questions or things you want us to add as we continue our webinar through this COVID era, just email back to the Malaku and myself, and we'll be happy to see and accommodate what your questions might be. I really want to say thank you to Malaku, who has been absolutely instrumental in getting this together in terms of the webinar. And I just want to say thank you to all my colleagues who jumped in short notice to actually be part of the conversation. So you all have a great evening in Ethiopia, and everybody have a good day here in the US. And see you guys on Monday. Bye-bye.